Well, welcome back. I hope you've had a bit of a break, had a walk around. I was slightly worried I was going to get a DVT if I was sitting here much longer. This session now is really about early pregnancy complications. We've got some great speakers. We have Thierry van den Bosch, Matthew Leonardi, and we have Davor Jerkovic, who is currently in Malmo running a course with Lil Valentin and Ligita, who you saw in the last oncology session. I'm delighted to introduce our co-chair for today. It's Yazan Abdallah. Yazan, very nice to see you. Yazan is I remember is at the Amman, I think, Medical Center in Qatar. Did a PhD at Imperial College London, was a consultant in Manchester, and now in Qatar. So and also having well, for those who don't know, Yazan, one of the papers Yazan wrote was the paper that really kind of changed things in terms of diagnostics of miscarriage. So probably one of the most cited papers out there, to be honest. So and is a specialist in fertility, IVF, and reproductive medicine. So perfect person to be chairing. Yazan, lovely to see you. I'm going to hand over to you.
Good afternoon to everybody, and thank you, Tom, for the introduction. It's a privilege to be here co-chairing with you and on such prestigious and important course. It was again a privilege to work on that paper under your supervision. It's a field that has come a long way, and it was a great landmark paper. Yes, indeed. We will start the session today with a talk by yourself, by Professor Tom Bourne, on the psychology of early pregnancy loss, a subject that around the time when much work was done on redefining safer criteria for miscarriage, some also as importantly critical work on the psychology of pregnancy loss was being conducted also by Professor Tom Bourne in Imperial College London, and that work has also come a long way. We're looking forward to hear that from you, Tom. Thank you.
So I'm going to now talk a bit about the psychology of early pregnancy care, which I think is a really critical topic for people who are caring for women and their partners in this difficult situation. So I'm just going to share my slides. Okay, so psychology of pregnancy loss. Well, this is a painting by Frida Kahlo, one of the greatest paintings of the last century. And you can see here where she is in the Henry Ford Hospital in Detroit, having just lost a baby, having had a miscarriage. And it's hugely symbolic painting. And we can talk about psychology of miscarriage as long as we like. But I don't think anyone is going to be able to replicate the intensity of the emotions you can clearly see here. Highly symbolic, the snail's pace the doctors moved at, the baby she lost, the own body, the pelvis, which she felt failed her, and the flowers that her husband, Diego Rivera, gave her, and the machine that took her baby away, all kind of connected by these umbilical cords. So obviously, when someone who went through such hardship in her life as Frida Kahlo is distraught as this, you can see that this is something that is associated with a huge amount of psychological distress. So we're going to talk about a few issues in relation to this, the scale of the loss, whether we can explain it to people to help their psychological well-being, maybe prevent it sometimes, and perhaps identify those who are at risk of developing problems. And we might touch on clinician well-being because I think that's an important factor as well. So quickly, this is a paper which really did change things a bit, I think, around the world in terms of appreciation of the load of psychopathology in this group of people. This is a multi-center study, 900 women, 700 with a pregnancy loss and some controls that were viable pregnancies. And I think the key thing to point out here is the level of post-traumatic stress. Anxiety is increased, but kind of goes down to not far off the control group level by about 9 months. But as you can imagine, people have moderate to severe anxiety for quite some significant time. And they also have depression, but this also decreases as well. But post-traumatic stress, obviously, not prevalent in the control group. But at 9 months, you're approaching 20%. So almost 1 in 5 women following a pregnancy loss have got moderate to severe post-traumatic stress symptoms at least 9 months after the event. In the 1 to 3 months, it's even higher. And that is a serious problem. It's not actually just the women. In this particular study, all the partners were male because that's what happened in terms of our consecutive recruitment. But you can see here that if we look at this cohort where we have recruited women and their partners, so the number at 9 months is a bit different. 21% of the women had post-traumatic stress, moderate to severe at 9 months, and so almost approaching 5% of partners. So that's about 1 in 25 partners, 1 in 5 women. So um, it's certainly not the case that men are not impacted by loss, and a significant proportion of them will have post-traumatic stress. But I think it's important to point out there is a difference. And so you can see here that in a couple, you've got a high likelihood of the woman having post-traumatic stress disorder, not so likely in the man, and therefore there's an imbalance in terms of what they're going through and the potential grieving response that they are going to go through as a couple. And perhaps that is why when you look at marriage and cohabitation after pregnancy loss, you will see that the number of relationships that are still intact go down significantly more in women who've had a miscarriage or indeed a stillbirth compared to where there's been a live birth. And as you go years on, it actually becomes even more the case. So clearly, this is very, very important given its impact on relationships, but it also has impacts in many other walks of life. Because what are the wider impacts of post-traumatic stress disorder? Well, I think you'll all be familiar with the issues around anxiety, depression, suicide, and substance misuse. But it also has socio-economic issues around relationships, which we've touched on, employment, people are unable to work, they have cardiovascular morbidities and various other physical problems. But I think what's not perhaps appreciated is that many women you talk to are too scared even to go and try again, and they never actually get pregnant. And you'll get this in people who've had multiple miscarriages in particular. I was listening to a lecture from Siobhan Quemby recently in the current miscarriage clinic in Warwick, saying that so many of her people just are too scared to try again. And if you do get pregnant, there are fetal risks associated with prematurity, low birth weight, and worse perinatal outcomes in general. So this is a major issue. And actually, we're only just looking at the tip of the iceberg when we say post-traumatic stress disorder, because when you talk about moderate to severe post-traumatic stress symptoms, you're using cut-off values, but there's still people who are having problems, even if they are below that cut-off value, defining them as having symptoms consistent with post-traumatic stress disorder. And if you look at this chart, I want to draw your attention to this month 9 data for the women in the study and look at these symptoms: helpless, terrified, helpless and terrified. Look at the percentages, extremely high. Look at the symptom clustering, hyperarousal avoidance, re-experiencing, and just day-to-day activities, not having problems with relationships with their families, having problems with having fun, sex life, general satisfaction, and so on. So, I mean, there's a whole group of people who are having problems because of they actually have post-traumatic stress disorder, but large numbers are suffering from very significant symptoms that are kind of impacting on their ability to go about their daily lives for a significant period of time. And when we published this work in this paper, as you can see here, it seemed to strike a chord. It got a lot of coverage in the media, actually around the world. And following these papers, we found it's almost as if people were given permission to talk about the trauma of pregnancy loss. And papers like Guardian in the UK asked women to give their experiences. As you can see, Guardian readers describe their experiences. And I think it just sort of opened a whole can of worms where people had just not felt they could talk about how they felt. And I think this is really, really important. I just want to go back to this issue, though, of length of time people have symptoms. This is a study from Portugal, and you can see here, this is patients who've been followed up for some years after the event. So this is 3 years after the event, 3 years, at least 15% of the women had, so that's about 1 in 6 to 7, had post-traumatic stress disorder. So the proportion with symptoms of post-traumatic stress disorder here, so that's after 3 years. And I think there's evidence from other studies that suggests even after many years, that these symptoms simply don't go unless they are treated properly. So we have a group of people who have a significant psychological problem that actually doesn't seem to get better. Now, we think they may be ameliorated should they be successful in having another pregnancy, although the data is not particularly strong on that. But in any event, this really is something that we should be taking very seriously. How do we identify this significant proportion of women who are going to continue to have problems for many years? And if you look at the overall picture, worldwide, 23 million miscarriages, that means 3.5 million women each year, 3 years after those miscarriages, will have moderate to severe post-traumatic stress symptoms. And then every year that goes by, you're going to accumulate another group of women. So the numbers are phenomenal. And this must be having a very serious impact from a societal point of view, both in terms of relationships, also in terms of the workplace, and therefore societal cost. Similarly, in the UK, for those who are watching it in the UK, 20 to 40,000 women with post-traumatic stress 3 years later. And you can look at this data everywhere. And indeed, if you look around the world, people are looking at this. I was actually at a meeting in Jordan recently, and I was interested to see this paper here. Sorry, excuse me, they were looking at the emotional response to miscarriage. Sorry, this is really annoying. And you can see here that how people agreed with certain statements that were made. Was their miscarriage down to fate? Slightly annoyed, ashamed. So a number of people are ashamed, feeling lonely, feeling guilty, and the loss of a child. So these are actually very typical feelings that we see everywhere. And so I think we do need to do some work to look at how different cultures and so on respond to miscarriage. But clearly this is something that is being reported and we're seeing, and I'm sure we will see all around the world. You can see how people coped with this. They asked for social support in a number of cases. Some took home remedies, and the various other, spiritual therapy, for example, and many, of course, did nothing or perhaps didn't need anything. So just important to say that this is a universal problem. So we've got some idea of the size of the problem. What about, explaining it? Well, we do know that if people understand why they've miscarried, they perhaps feel less guilt. And if they feel less guilt and have this lower self-blame, the incidence of psychopathology is thought to be lower. And of course, we always say quite commonly that it's probably due to a chromosomal problem, but of course, we don't test for it. So this is Nina Parker, who's PhD student at Imperial, who's looked at how or whether we can use a simple blood test with cell-free DNA testing to explain the cause of miscarriage. So generally, we're not looking at using cell-free DNA in the early parts of pregnancy, and the understanding being that it really doesn't work. However, Nina has looked at maternal blood and pregnancy tissue, so cell-free DNA versus standard cytogenetic testing, and a cohort of 308 women who made the final comparison who'd sadly undergone miscarriage. And we found this. First of all, in this cohort of women who are undergoing miscarriage, 98% of patients can get a cell-free DNA result, which is way higher than we would have expected. And it doesn't matter what gestation. You can see from 5 weeks, that's with 108 patients, all the way up to later in pregnancy, lower numbers here. We're finding that we have successful results with cell-free DNA. And if you look at the actual results themselves, for all cases, the accuracy is about 80%, sensitivity 70%. If you exclude cases which the platform that we used, which is the Illumina platform, who did actually help us with some of the laboratory work, for the non-detectable abnormalities, we found accuracy of 86% and sensitivity of 80%. However, the important thing is that there's 100% specificity and 100% and no false positives, and that's critical. So in this population, where if you tell someone there's an abnormality, that explains their miscarriage, it's acceptable that we don't detect all of them. So that level of sensitivity is perfectly fine in this population compared to, say, the population for the nuchal scan at 11 to 14 weeks and around that gestation, because we're looking to explain the cause of a miscarriage. We don't have to identify things in every single case. And if you look at test performance, it holds up across all gestational ages. And interestingly, if you look at the cell-free fetal fraction, which is usually the marker of how successful you're likely to be with this test, interestingly, none of the things you'd expect to influence it did so. So the size of an embryo, sorry, as you can see here, the clinical gestational age, the size of a gestation sac, ultrasound-based gestation age, or even the size of the weight of the patient. None of these altered the fetal fraction, which, as you can see here was probably around 6% across the board. And if we look at the ultrasound findings, again, scan findings, ethnicity, or the bleeding score, none of these made a difference to the likelihood of success. And we got a result whether there was an embryo present, whether there was an empty sac, or even when there was just retained pregnancy tissue. So it seems fairly clear that we should be able to use cell-free DNA to get results so that we can explain the cause of a miscarriage to most women. What about reducing post-traumatic stress symptoms? Well, this is, I just wanted to highlight something that's been happening in our unit. Tetris, some of you remember is a computer game. Emily Holmes has shown that you can use Tetris gameplay to reduce the number of post-traumatic stress symptoms, and in particular, in the number of flashbacks. So we've carried out a study using Tetris where we have taught with supervised Tetris gameplay how to mentally rotate these blocks to fit in into the Tetris game. So that's the intervention group, takes about 15 minutes. And the control group, they listen to a kind of standard, fairly boring podcast. But have a look here at 5 weeks. This is the active control where we had the intervention. We've halved the number. Sorry, this is the intervention and this is the control. We've halved the number of intrusive memories. And at 3 months, you can see that over half we've reduced the level of post-traumatic stress disorder, again, probably by about 60%. That's at 3 months. Now, we need to see whether that continues up to 9 months. But for an intervention, which perhaps you might think is almost ridiculous, we are able to reduce post-traumatic stress symptoms in women who have had a loss. And I think this is really quite exciting with the potential for rollout. Because we need to consider, what does work and how do we, first of all, we want to reduce people with post-traumatic stress, but then we want to identify people who have got it, because currently in most cases people have no follow-up. However, they need specific therapy, either CBT, which is trauma focused, or EMDR, plus or minus drugs so that people can buy into therapy. What does not work is simple, support, social support, going online to help rooms, and so on. That will help a lot of people who have what you might call a normal grief response, because that will resolve over time to some extent. However, in the 20% or so patients who've got post-traumatic stress disorder, we need to identify them and deliver appropriate treatment. We know, looking at our study, that we can't really pick out that many prognostic factors that's going to pick out which women are going to have this problem. And so what we've done is to try to see on a pilot study whether we can do it with screening. This is unpublished data. It's a pilot of 500 women who were sent, 78% of women who had a miscarriage in our study opted in to having a text message sent to them 2 months after their loss, and asking them if they would fill in a Core 10 survey, which is a validated survey which will give us information about post-traumatic stress and other psychological morbidity. So only 25% of these women actually filled in the core survey, but 65% of these, or the ones who responded, had clinically significant psychological distress. And overall, if we look at everyone who was sent a text, 16% had psychological distress. So although we don't get buy-in and people do not always answer the text, we're almost getting up to the same number of women we identified in the study. We know that approaching 20% of women have worrying psychopathology and post-traumatic stress. And by using this simple text follow-up, we're identifying about 16% of women who may benefit from treatment. And indeed, most of these consented to referral for therapy, and 75% of the women who've undergone treatment have shown a significant clinical response. So we can tell people why they've miscarried, potentially. We might be able to reduce symptoms. And this is a reasonable and deliverable and scalable approach to trying to identify women who would be who would benefit from appropriate treatment. It's not going to get everybody, but in a health service where we can't follow everybody up, probably, this is a logical and reasonable way of doing it. Finally, I just want to say, please be careful, what we say to people. We don't know all the factors that lead to people being traumatized by miscarriage, but one thing I think which we can do is think about how we speak. We shouldn't be using spontaneous abortion to describe miscarriage. We shouldn't be using retained products of conception. As Katie Lindemann so eloquently says, don't call my baby a product of conception. So let's just think about the words we use. And in day-to-day life, just try and change the nomenclature. Surgical management of miscarriage. We don't use spontaneous abortion. We don't use products of conception. And perhaps avoid language that minimizes the loss. Repeatedly, patient groups will tell you this is not the appropriate language to use. Simply just say, I'm sorry. I'm so sorry what's happened, that you've lost your baby. We don't need to offer, explanations or comments to try and say that it's inconsequential, because of course it's consequential. They've just lost their baby. My last word is going to be about you, about the doctors. Obviously, we need to look after women with early pregnancy loss with compassion and with empathy. But the problem is we can't always do that because a lot of people working in the profession are burnt out. This is a study of obstetricians and gynecologists following the pandemic in the UK. Just look here. Trainees, 2022, 80% fulfilled the criteria for burnout, and 70% roughly of SAS doctors and consultants. First thing that goes, or some of the first thing that goes with burnout, is you lose empathy, you lose compassion. So we always need to be mindful that we need to make sure that staff looking after patients in early pregnancy are equipped and are able to, and their well-being is a level that they can look after patients appropriately and make sure they care for them properly. Because they're not only burnt out, a number of them can't sleep. You can see the proportion here. Those with burnout have sleep problems, anger, irritability, gastrointestinal symptoms, and a number of them, have symptoms or have suicidal thoughts. Actually, quite a shocking number. So if you don't look after the staff looking after people, you won't get good care. And we know that burnout is associated with unprofessional behavior, increased patient safety incidents, and so on. So it's a really important part of the whole picture. So to summarize, I think we've clearly demonstrated psychological distress is really quite high following pregnancy loss, and it can last for many years. That's the point. So we need to think about how we capture these people, intervene and treat them. We can now think of how to explain to people why most of them miscarriage. If we get good validation data on cell-free DNA testing, I know this isn't going to be an option in many places in the world, but it is going to be a starting point in some. Tetris gameplay can reduce intrusive memories. This is simple and can be done anywhere, even on a telephone. If it's properly taught, it's a supervised gameplay for 15 minutes, seems to reduce symptoms, and that's something which I think we're going to hear more about. I think we need to think about following up people who've had a pregnancy loss to try and capture those who are suffering particularly from moderate to severe post-traumatic stress, so we can give them appropriate treatment. I don't think we're going to be in a situation where any health service is likely to be able to see all of these people, but I think that proportion of women who have moderate to severe post-traumatic stress, we need to have an holistic approach. And I think we've shown that a text message follow-up system can enable people to do this. Finally, you need to take care of the workforce. If you're burnt out, it's hard to show empathy, and I'm sure that transmits to patients. I'll leave you with this picture of Frida Kahlo. She never got over her miscarriages, and she unfortunately never had a successful pregnancy. And this doll um, represents the baby she never had. So um, just remember the long-term effects of miscarriage, and just remember when someone's had a miscarriage and they come back to see you in early pregnancy, and they've perhaps got post-traumatic stress symptoms, how scared they must be when they come to see you, and how difficult it must be for them to even contemplate sometimes getting pregnant. Um, I think it's extraordinary, really, how they managed to do this. So I'll leave that with you. I'll just stop sharing my slides, hopefully, if I can figure out how to do it. And here we are, and I'm very happy to answer any questions.
Thank you, Tom, for this very informative and important talk on the psychological aspect of pregnancy loss, and also an important final point on the well-being of doctors who are caring for these women, and ultimately the well-being of the caring doctors reflects on the quality of care delivered to these women or these couples who suffer with miscarriage. At this point, we'll take questions if there are any before we move on to the next talk.
Yeah, that's fine if you're happy. I mean, I think there's no questions from the slide here. I mean, one of the questions I perhaps discussed with you is we don't know much about. This was a study looking at post-traumatic stress and so on in a London population, and I just wondered if you put your perception, because obviously everyone's different, different religions, different cultures. You're living in a different culture now, and so on. But
Yeah.
I mean, I personally think it doesn't matter. You know, you lose it, you've lost your baby. You know, that's the end of it. But one of the questions we've been asked has been, you know, look, what is this is this generalizable, if you like? What's your feeling?
I think this is an excellent question, and having practiced the majority of my medical work in the West, in the UK, and now having moved to the Middle East for the last 5 years, there is some contrast to be drawn. I think it's because people react less severely to pregnancy loss. I think a pregnancy loss to a mother is a pregnancy loss to a mother from whichever culture they come, and I think they grieve, and they grieve regardless of what belief system they have or not. Do you think there are differences, which are the age at which women start building families, and in parts of the world where women embark on childbearing very early, they build bigger families. They have more children. They tend to have more children, and that somehow, I mean, it doesn't make a pregnancy loss less impactful, but they suffer with pregnancy loss less because chromosomal abnormalities are less. And when they're busy with a number of children, I don't think, I think their busy schedule or busy lives is a very powerful counseling tool to them. It takes them, you were talking about the tools that you present to women to, as a cognitive therapy. And I think, being in having this size of family is also in a way is a helpful tool. And also the early the childbearing at early stage, because the later you leave it, we know that infertility rates increase, and with the increase in infertility rates, there's an increase in pregnancy loss, and then in pregnancy loss
I think we've lost you, Yazan.
itself starts to become more significant psychologically. It's a long women are a bit more anxious about keeping pregnancy at that stage.
Well, it's interesting to hear. I mean, it's obviously something which, you know,
I don't know if my
we would
if
like to
the audio for it was.
no, we'd like to replicate the study in different countries, really. So if anyone's interested, do let me know. I think we have to move on, Yazan.